Good morning, ladies and gentlemen. Let me warmly welcome you to another session of the weekly Sunday webinar series brought to you by the Society for Health Research and Innovation. Today's lecture is on hypo and hyperpigmentation on the face. The resource person for today is Dr. Ranthilaka R. Ranawaka. She is a consultant dermatologist of the Lady Ridgeway Hospital for Children, Colombo. She has 28 research publications in index journals, author of 27 book chapters internationally, editor and author of 8 medical books nationally. She has always been an integral and a consistent part of the CPD webinars. She has conducted a number of very practical lectures on dermatology. So I warmly welcome Dr. Ranthilaka R. Ranawaka for today's lecture. Over to you, madam.
So, good morning. Our topic today is hypo and hyperpigmentation on the face. So we'll first talk about hypopigmentation. So there are many causes: pityriasis alba, leprosy, pityriasis versicolor, photodermatitis or polymorphic light eruption, or we call it PLE, vitiligo or halo nevus. Pityriasis alba. So this is a common problem in children. You can see this rounded or oval and mostly irregular hypopigmented patch on the cheek, usually bilateral but can be unilateral, and it is poorly marginated. And it lasts for many months or years. So this is predominantly in children between the ages of 3 and 16. It is a manifestation, often a manifestation of atopic eczema, but it can occur without atopy even. So usually this is due to dry skin. So the management is emollients. So we give a moisturizer, emollient, to apply about 2 to 3 times per day. So usually disappear within few months. Second is leprosy. So again, this is a girl. You can see this hypopigmented patch. There are 2 patches on the face, and she had other patches on the trunk also. You can see this hypopigmented patch is well demarcated. Sometimes erythematous, sometimes slightly raised. Even here you can see the smaller one is not raised, but the larger one is raised and mildly erythematous. So this is leprosy. So if we can elicit sensory impairment, hypopigmented patch with sensory impairment, that is enough to diagnose leprosy. But the problem on the face is there's no sensory impairment on the face due to overlapping nerve supply. So we may have to, if there's no other evidence of leprosy on the body, other areas of the body, we may have to go for a skin biopsy. So if we see skin patches, 5 or less, it's called paucibacillary leprosy. More than 5 are multibacillary leprosy. So this one, again, you can see this hypopigmented patch. Hypopigmented patch. Again, almost well demarcated, but not entirely well demarcated, but clearly demarcated. Okay, then sometimes these are itchy, sometimes eczematous, and it is mainly on the malar area, along the zygomatic arch of the face and on sun-exposed areas. So this is recurrent It's a delayed onset or abnormal reaction to sunlight or even artificial UVR. Like in a tube light also, they can get photodermatitis that resolves without scarring. So diagnosis is clinical, management, avoid sun or artificial light, and they may have to use protective measures like wearing a hat or wearing a covering or something like that. Then they have to use sunscreens. Sunscreens, SPF, that is sun protection factor, it should be more than 50 or more. So if it's itchy and eczematous, we give mild steroids, but steroid is not essential. The most essential thing is sun protection. And even if we give steroids, it's for a short period. So it takes long time to resolve this hypopigmentation, few months to sometimes years. So this one you can see, again hypopigmented patch with lot of satellite lesions, and they are discrete, and you can see some are elevated with a well demarcated edge. So this is pityriasis versicolor. And after a bath or after they wash and dry, this scaliness become more prominent. So this is pityriasis versicolor. So you can see this one, asymptomatic. This is not hypopigmented, but this is depigmented. No pigmentation at all. And sometimes you may find it difficult to diagnose, but most of the time it's very obvious, right? So this is vitiligo. It's well demarcated, depigmented patches. This is a halo nevus. That is, this child has had a melanocytic nevus, small melanocytic nevus for a long time. But within last few months, there's depigmentation appearing around the nevus. This is called halo nevus. It's again a benign condition. And this sometimes when halo disappears, the nevus also disappears. But sometimes nevus disappears, but this depigmentation may last for few months to years. But anyway, this is not vitiligo. So, but it can coexist with vitiligo. And in white skin people, this nevus can be even melanoma because this halo can appear around a melanoma. So, but not in our skin. So anyway, no treatment required, reassurance, and it will disappear spontaneously. Then let's talk about hyperpigmentation. So in our setup, hypo and hyperpigmentation are both important, but people are more concerned about hypopigmentation because it's more prominent and easily visible in darker skin. So hyperpigmentation, most of the time we ignore because it's not a big issue in dark skin. But this is a problem in middle age. After 35 to 45, lot of people get hyperpigmentation on the face. So one is freckles, then melasma, ashidermatosis, lichen planus pigmentosus, there's facial acanthosis, sebomelanosis, periorbital hyperpigmentation, hair dye melanosis, and some medical issues like inflammatory diseases causing facial pigmentation, as in systemic sclerosis and lichen planus. So this is freckles. Freckles are not common in our skin, but some people with a family history of predisposition, they get freckles on the face. And usually freckles are hidden in our dark skin. Therefore, it is not visible. But if people having fairer skin, these freckles become more prominent. This is very common in white skin. Freckles are not common in pigmented skin. It's common in fairer skin and white skin. So the problem is exposure to UV radiation leads to overproduction of melanin by melanocytes. So this is a type of a sun damage to the skin. So differential diagnosis is lentigens. Lentigens persist even without UV exposure, and lentigens are common in old age. And lentigens, there's no relation to sunlight. So lentigen can appear even on unexposed areas. So here the management is, so we can use chemical peels, lasers, topical depigmenting drugs, and most importantly, photoprotection. Again, melasma. Melasma is very common in dark skin, and it is a big problem in most of the middle-aged women, but even in 10% of men. So my advice is to treat melasma early, right? Most common cause of facial melanosis in middle-aged men and women in our setting, and more pronounced after a sun exposure. And it is very common in women, but also in 10% of men. And this is exacerbated by sun exposure, combined oral contraceptives, and other hormonal treatments. So after pregnancy, during pregnancy, usually this appears and then it persists. So even if when they take OCP, this can appear and it can persist. Even without any hormonal imbalance or hormonal issue, middle-aged men and women gets melasma. So it is important to determine whether it is epidermal, dermal, or mixed, because with our topical therapy, only epidermal melasma or epidermal component of the melasma disappear. Dermal part does not respond to topical treatments. So dermal melasma is generally less responsive to therapy, particularly to topical therapy. So whatever the expensive treatment we use, unless we practice the protective measures, this reappears. So they have to maintain it, and sun protection is very important. So if their occupation or day-to-day life is related, where they have to go to sun, like they can't avoid sunlight, I don't think it's not worth taking treatment for melasma. So management option, sun protection, that's the most important thing. And use broad spectrum sunscreen with sun protection factor more than 50. And topical therapy, we give combination of hydroquinone, tretinoin, and corticosteroids. Since there's corticosteroids, when it improves, we have to stop the drug. Otherwise, they get side effects due to corticosteroids. Also, since it has tretinoin, this cream is applied only during the night. And since it has hydroquinone, they can't keep on applying because they can get side effects due to hydroquinone. And they can get reverse hyperpigmentation because of this hydroquinone. So this triple therapy you have to prescribe very wisely, and you have to explain the patient the side effects, the duration they use, usually 1 month. Then they have to use other modes of sun protection. Then chemical peels we can use alone or in combination with topical treatment. Laser therapy, again in selected cases, and again with topical therapy, because you give laser, then they have to maintain with topical treatment. Dermabrasion is the same. So whatever the expensive mode of treatment they use, they tend to recur unless they use strict sun protection, which is very, very difficult in our country, right? So this is facial acanthosis, and these are asymptomatic, and oh wait, symmetrical darkening start at malaprominence of the face and forehead, spread to involve whole face. And there are significant association between impaired glucose tolerance and increased body mass index, so obesity. So like when we see this, when they come with facial acanthosis, or when we diagnose acanthosis nigricans, we have to look for impaired glucose tolerance. We have to do the lipid profile and their cholesterols, and they have to control their weight. So weight reduction is important. The other one is ashidermatosis or erythema dyschromicum persistens. You can see this woman's normal face color is behind the eyes. You can see the color, and the forehead, you can see this shiny, grayish, uniform skin. So this is characterized by numerous macules of varying shades of gray color, right? Occurs in both sexes, but common in women. Cause is not identified. So diagnosis is clinical. Sometimes we do histopathology for confirmation. And the treatment, there's no consistently effective treatment. So there are various drugs used: clofazimine, dapsone, oral and topical corticosteroids, UV therapy, but with variable response. And this is again a very common problem, periorbital hyperpigmentation. There are many causes for that: atopy, lack of adequate sleep, prolonged exposure to computers, rubbing eyes, application of various cosmetics, or even acanthosis. So we have to find why, causative factor in particular patient, and we try to treat the cause if we found it, or otherwise there are various eye creams, standard eye creams they can apply, but you should not prescribe steroids around the eye, because even with topical steroid, there's a risk of getting glaucoma. Therefore, unless that drug is made for periorbital application, do not prescribe anything other than that. You have to prescribe only a very reliable periorbital cream. There are creams like that. Light eyes, bionic eye cream, and various names are there. So this is called sebomelanosis. Again, it's a very common problem in young men and women around 20 to 35 years of age. And this is asymptomatic, but sometimes mildly itchy, but it's a very big cosmetic issue for these young people. And almost all of them have oily skin or seborrhea. So, but usually they don't have other skin problems associated with seborrhea, such as acne, seborrheic dermatitis, dandruff. They may or may not have. So this is called seborrheic and it is seen only in this Asian skin, South Asian skin. So management is like, if we know if they already have seborrheic dermatitis, we treat for that. And if not, we may have to use various depigmenting agents, keratolytics, salicylic acid peels, again topical isotretinoin, laser, combination of hydrocortisone and antifungal like Candacort, but it's for a short period. But again, it's poor response and frequent recurrences are common. This is lichen planus pigmentosus. Again, you can see it can be diffuse or patchy, hyperpigmentation. Sometimes they have associated lichen planus, but they may not have lichen planus. So to differentiate with other hyperpigmentary disorders, we may have to do a biopsy. So again, I would say it's rather difficult to treat and sun protection is advised. So hair dye melanosis is again very common among middle-aged men and women, mostly women, because they are the people who are very much concerned about gray hair. So this is prolonged use of black hair dye causes blackish pigmentation. You can see this blackish pigmentation on the scalp extending to the forehead, pinna of the ear, and the sometimes zygomatic area, right? So it's uniformly spread over the affected area. So management again, topical retinoid creams, again triple therapy, combination of 3 medicines, and sometimes laser. Because this hair dye melanosis is like tattooing. Because if we do a biopsy, this hair dye has gone up to the dermis. It's like a tattoo, right? So again, difficult to treat. So there are other medical issues, medical problems which can cause hyperpigmentation on the face. One is lichen planus. So this woman had lichen planus on the other areas of the body, typical plaque-like lichen planus. But on the face, they have these patchy, some like plaques, but some like macules. And in systemic sclerosis also, they get generalized hyperpigmentation. So in these cases, we treat their medical issue, not the facial pigmentation. So in summary, we'll take this hypopigmentation. Now see this hypopigmentation. Hypopigmentation, you see this is pityriasis alba, photodermatitis, vitiligo, leprosy, versicolor, halo nevus. All are hypopigmented issues, but there are clinical differences. So you have to differentiate and make a correct diagnosis and correct treatment. In these cases, in hypopigmentation, except for vitiligo, all others are curable. But hyperpigmentation is a bigger problem and much a bigger problem in our setting in darker skin individuals, because with aging, wrinkles are not very common in our skin, dark skin. So we don't get wrinkles at the age of 35 to 40, such as in white skin. White skin people, they start wrinkles at the age of 35, 40. So we get wrinkles around even after 55, we have a fairly good skin. But our problem is at the age of 35 to 40, we start getting pigmentation. So actually, this hyperpigmentation on the face is a feature of aging in dark skin individuals. So this is freckles, melasma, this is hair dye melanosis, facial acanthosis, sebomelanosis, lichen planus pigmentosus, ashy and lichen planus. So you can see there are various types of, there are various causes for hyperpigmentation on the face. So you have to differentiate and then decide the management. So as every day I tell you, dermatology is visual diagnosis. And so you have to get used to the clinical appearance. So now we have done, earlier we didn't have books of our patients. So now we have books written on our patients. So you can go through and get used to the appearance. So get familiar with more and more clinical photographs. So there are all these books are in PGIM and SLMA Medical Library. And in this particular book, Atlas of Dermatosis in Pigmented Skin, we have a separate chapter on facial melanosis, because in before 2018 even we identified this facial melanosis as a big problem in our skin. And here also in this book, Dermatosis in Dark versus Light Skin, we have compared the same skin problem with white skin and dark skin. Here also there are few chapters where there are no patients seen in white skin, like in hair dye melanosis, sebomelanosis, and facial acanthosis are only confined to dark skin individuals. Dark skin means type 4, we are type 5 skin, 4 and 5 skin. 1, 2, 3 are white skin. Right. So, question time. Wait, I can see some questions. Chat. So shall we start questions now? You ask.
Madam, I will ask questions in the chat box. The first question is how to differentiate idiopathic guttate hypomelanosis from vitiligo.
Vitiligo and idiopathic guttate hypomelanosis. Idiopathic guttate hypomelanosis is entirely a different entity. But so my topic is on the face. That's why I didn't include this, because this guttate hypomelanosis we don't see on the face. It is mainly on the shins, legs, shins, and it is they are on elderly population. Again, it's more common on dark skin. Therefore, theory behind that is with aging of the skin, that there are loss of melanocytes. That is the theory behind this guttate hypomelanosis, and it doesn't spread, and it doesn't go all over the body. It's confined to shins, legs, and along the shin, and it doesn't disappear also. So you have to reassure patients It's very common in our skin. Middle-aged and elderly, usually women, they come and show us these vitiligo-like lesions on legs, which are confined to legs and does not appear on any other areas. And I told you that the theory is that there's loss of melanocytes during aging. So there's no treatment for that, only reassurance. And you have to tell them there's no treatment and we can't cure also. Reassurance, that's all. They are happy with reassurance. They are worried that it is vitiligo. So when we reassure, they are happy actually.
The other question, what is the best responded and cost-effective treatment for pityriasis versicolor in Sri Lanka?
Pityriasis versicolor, I did a lecture on fungi. There, we have to use topical antifungal, right? It can be anything, clotrimazole, miconazole, terbinafine. There are newer drugs. Loseril cream has something else. Like that, there are various antifungals. So you can use any of those. They have to apply for 1 month. And if you decide to give oral antifungal, the best is itraconazole. So you have to give itraconazole in adults 100 BD twice daily for 1 week. 7 to 10 days maximum. That's enough. Then you have to reassure the patient. This hypopigmentation may last for years sometimes. So if this scaliness has disappeared, that means the fungi is gone. Right, next question.
What is the role of vitamin C and retinol serums in the middle age?
Vitamin C and?
Retinol serums.
In what? Pigmentation.
In middle age pigmentation.
That I don't know actually, because there are now I did actually, a lot of people are interested in this cosmetic dermatology. But only thing you have to make as I showed you, in hyperpigmentary issues, there's a differential diagnosis. It's a big differential diagnosis. So you have to make a diagnosis and do whatever the treatment. But this vitamin C and serum, I know there are various serums and this I don't know actually.
Manu, is there another question? Can we use laser therapy on children?
So I didn't hear your voice is, where I'll see that. Sorry, what?
Can we use laser
Therapy on children? That's the
Yes.
question, no? No,
Yes.
laser, yes. We don't have at the moment laser on children, but we can use laser on children for various other issues. They don't have these pigmentary issues now. They have only hypopigmentary issues in children. Hypopigmentation is 100% cured, right? Hyperpigmentation in middle age and elderly is the problem, which we can't most of the time cure. So in children, we use laser on hemangiomas, sometimes nevus. We can use, yes, no contraindication, yes.
Facial is reversible with glycemic control. If it is persistent, is there any treatment?
Yeah. So that is facial acanthosis, I think, no?
Yes, facial acanthosis.
Yes. No, most of the time, they have to do weight reduction and glycemic control. But because otherwise, even after treatment, that won't last. It will recur again. So for facial acanthosis, there are topical creams made for that. But usually they are all combinations. So you can read like when a pharmaceutical company person comes, you can get a sample and read what are the combinations they have. So there are about 5 or 6 ingredients are in it. So I don't know like exactly which acts, but there are a lot of ingredients there. So there are drugs made for facial acanthosis, topical creams, right? So that one, but glycemic control and weight reduction is essential because otherwise this will recur again, right?
Madam, you said there are certain types of cosmetics that can cause periorbital hyperpigmentation. A question asking what are the cosmetics that can cause periorbital hyperpigmentation?
Yeah, cosmetic can cause. Yeah.
Yeah, what are the types of cosmetics that can cause periorbital hyperpigmentation?
Like exactly, I don't know, but there are some people who use eyeliners to almost every day. So even if you use eyeliners, this black pigmentation you get due to PPD, paraphenyldiamine. So as I told you about hair dye, the same thing can happen. This dye can go into the dermis. So it's like a tattoo there. So using dark eyeliners daily or very frequently, they can get this tattoo-like effect. Just like hair dye melanosis.
Madam, there's another very interesting question. Is it safe to use glutathione containing local applications for facial hyperpigmentation?
Uh, what is the drug?
Glutathione containing local applications.
මෙහෙමයි. Topical application, I can't recommend because you can't apply uniformly. That is the problem there. So there are a lot of depigmenting creams which has glutathione. The problem there is you can't apply uniformly. So we get people who have hypopigmentation on the face because they have applied the cream there. So with time, they get hypopigmentation on that particular area only. That is the problem with topical depigmenting agents. You can't apply uniformly everywhere. But glutathione tablet, it will work uniformly. It is an amino acid and it's a over-the-counter, it's not a drug, food supplement in Australia. It's over-the-counter, you can take as a food supplement because it is an amino acid which is in our body. But after about 6 months, when you stop this taking glutathione, you get your normal skin color. And the other problem when you use these depigmenting drugs, so with melanin, we have a protection. We are protected from UV radiation. So we are in a tropical country, exposed to sunlight all the time. And most of the time we don't use umbrellas, hats or sunscreens because we were born in this hot climate. We are used to this hot climate and we love the sun, right? So it's not a problem for us. So like now you have with glutathione or any other depigmenting creams or tablets, you have removed melanin, that protection we get from melanin. So actually the effects we get, we have to wait for another 10 to 15 years to see the effect of these depigmenting tablets and creams. Like in Australia, they have a big problem of skin cancer because the people, white people, are not the native people in that land. So after million of years, these white people, if they want to survive in this land, they have to be pigmented. Otherwise, they won't survive. That is evolution. So like that, to see the effect of this depigmentation, we may have to wait for another 15 to 20 years and see whether we will get more skin cancers. So far, skin cancer is not an issue in Sri Lanka and in these our countries because we have a protection from melanin. Right.
Madam, what are the treatment options that are available for vitiligo?
Treatment options, so it's an autoimmune disease and the treatment is steroids. So nowadays there are steroid sparing drugs which are immune modulators like tacrolimus. So our first line treatment, topical treatment, if the lesion is small and short duration, our first line treatment is topical tacrolimus. It's very effective and most of the time we can cure early lesions. But if they come with a very extensive, not very extensive, but we'll say it has started spreading very fast, then we have to start oral steroids. But if they come with very extensive vitiligo, so I won't start anything, like no use of starting anything. But anyway, this is an autoimmune disease. Our aim is to stop autoimmune process. Stop the progression of the disease. That is our aim, not to cure. I explained them. We can cure only very small lesions and very early lesions only. Otherwise, our aim is to stop spread of the disease. Stop the spread. Next.
Madam, there's a very recurring question. Everybody's asking this. Can you please recommend a good topical local application for periorbital hyperpigmentation?
So periorbital hyperpigmentation, there are various drugs. As I told you, they are all mixture of various things. So, there was a drug called Light Ice, right? I think that is SS Pharmaceuticals. Then Bionic Eye Cream was there. So all those two drugs, I am not sure whether it's available now. And there's a BioBalance pharmaceutical, they have a eye cream for this, right? So make sure don't prescribe topical steroids, although these eye creams also, they have a component of steroids, but it's a combination and very mild steroid. So don't give only hydrocortisone, only Candacort or something like that. Don't prescribe that because the patient can get glaucoma, right? So, but these eye creams, which are made for periorbital pigmentation, are safe and effective also. In BioBalance, that's a pharmaceutical company named BioBalance, they have a eye cream. It's very effective. They have to apply about 1 to 2 months. Right.
That question is a very common presentation to primary care these days. What is the treatment for this chikungunya nose? You get the hyperpigmentation around the nose and the mouth following chikungunya fever. Is there any treatment for that we can give?
No, I don't think so. We have to wait and see. Just observe without doing anything, because most of the time these are post-inflammatory hyperpigmentation. So post-inflammatory hyperpigmentation goes off spontaneously. Because for whatever these hyperpigmentation, most of the time steroids are there. So if you apply a steroid on face unnecessarily, the problem is they can get acne, striae, and even atrophy. So I had only one patient. So I asked them to wait for 3 months and come in 3 months. So we have to wait and see how it goes off. Usually post-inflammatory ones, it goes off spontaneously.
The other question is how to treat this hyperpigmentation caused by cosmetic products that contain mercury.
That I don't know. That I don't know. Because actually, what are the indications for laser therapy? That's a big problem, good topic, but actually I don't know because I don't do lasers. So you have to get down one of the consultants, dermatologists who do lasers and ask what are the indications for lasers on hyperpigmentation. How you decide when to go for laser? I don't know that.
Is it recommended to use mild steroids for pityriasis alba in children? Or there's any other management other than emollients?
For pityriasis alba.
Yes.
Pityriasis alba is due to dry skin. So emollient is enough. If they apply emollients twice daily for 1 month, this disappears. That's enough. Any other questions? All right. So there's a question when pityriasis versicolor not respondent to microral cream, what is the next option? First thing, they have to apply microral cream for 1 month. Microral or any antifungal cream for 1 month. Second, you have to reassure them that this hypopigmentation may last for years. We don't treat until it disappears, because when the scaling disappears, that means there's no versicolor anymore. If there's very extensive versicolor, you give itraconazole 100 BD for 7 to 10 days. Right? Here, one has asked, explain conditions that can cause both hyperpigmentation and hypopigmentation. No, I don't think there are conditions. Only post-inflammatory you can get hypo and hyper both. Right. And then use mild steroid for, no, pityriasis alba, I don't think you have to use steroids. No, avoid steroids as much as possible from the face, right? Because you cause unnecessary problems. Hyperpigmentation following tinea skin infection. Actually, there's no treatment. That's a post-inflammatory hyperpigmentation. And I explained them, it's rather difficult to get rid of this hyperpigmentation. With time, it will go off, but it usually lasts for about 10 to 15 years even, right? They are really worried, but can't help, right? Now got a fixed drug eruption, right? Still there, right? So for fixed drug eruption and pigmentation, its only treatment is mild topical steroids. But the most important is you should not take but you have to identify the drug, should not take the drug again, because whenever you take the drug, you create more and more fixed drug eruptions, and the persisting eruption become more darker and larger. So avoid the drug, offending drug, and mild steroids. That's all, nothing.
Madam, I think we are running out of time today.
Okay.
There's a lot of questions.
All right. So what shall we do? Finish?
We can do another 5 minutes. We can do
All right,
till
okay.
10:35.
Oh, if you want, you can ask me.
No, madam. No, that's all right.
Right. So there's darkness around the corner of the mouth. Yes, it can be whether it is seborrheic or contact saliva. It can be either or both. So with seborrheic also, they get this pigmentation, saliva, contact saliva also they can get. So you have to talk to the patient and find what the problem is. This contact saliva, you can't ask them because involuntary. You just observe while talking to them. You observe their face and see whether they do lip licking. Because it's a involuntary behavior. So they don't admit they do this lip licking. So you have to observe. So depend on the cause, you treat that, right? Can be given for acanthosis, I told. There are various drugs made. Oral glutathione. Oral glutathione dose එකනම් මෙහෙමයි. I gave only one tablet daily, but that they have to wait for about 6 weeks to see the response. Then the patient has to decide how much they want to get light color. That is their opinion, not mine. No. So they have to decide. So after they come to like their expectations, then they have to maintain it. So they have to maintain taking about tablets about 3 times per week. Initially they take daily, then 3 times per week. They maintain it. As I told you, you have to explain them the risk of cancer because we have to wait for another 10 to 15 years to see the effect of these depigmenting drugs in a tropical country. In our country, we didn't have these problems earlier. Now only that this glutathione came. It's not a toxic drug, but in 10 to 15 years, these people might get more and more skin cancers. We don't know. We have to wait and see. Topical steroids used on face? No. If you want only hydrocortisone, but better avoid steroids on face, right? Long term, to take glutathione long term. So I explained that. It's an amino acid. No short-term side effects are not there because it excretes in urine. And if you stop the drug, your skin color becomes normal because it usually excretes in your body. So the side effects, we have to wait and see with light skin, what will happen to our light skin in a tropical country. Into 15 to 20 years, we might get more and more skin cancers. And also skin aging. Because our skin is protected by melanin, so we don't get UV damage to our skin is minimal, right? But white skin, they start wrinkles at the age of 35 because they don't have this UV protection. So they might get skin aging very early. They might get skin cancers very early. So that is our assumption with loss of melanocytes or reducing melanocytes in our skin. So dark skin Sri Lanka survive in Sri Lanka, in Australia, yes, but only thing is there's a damage in ozone layer. That particular area, Australia and New Zealand, the ozone layer is damaged. So they are exposed to different UV radiation than us. So again, we have to wait and see for 10 to 15 to 20 years and see whether there's any change. But as I told you, we have to respect the nature, and this is evolution. So if somebody live in a tropical climate, definitely these white people, if they want to survive, they have to get more melanin. So in, I don't know, 1,000 to 2,000 years, they will become darker. Otherwise, they won't survive. That is evolution. Whatever you do, you can't go against nature. Right? Then, when you are finished, you let me know, right?
Madam, we finish at 10:35. There's like a lot of questions. It is usual
Right.
lectures.
Okay, 2 minutes only now. Many conditions of hyperpigmentation are related to overexposure to sunlight. No, I don't think so. Overexposure, but most of these hyperpigmented. Now I taught you the causes, but all these hyperpigmentary issues get worsened with sunlight. Worsen with sunlight, right? It is not the causative factor, but it becomes worse. And many are vitamin D deficient, yes. I agree with you, but vitamin D deficiency, I think we have to do a lot of other research on medical people have to do research and see why we are deficient in vitamin D in this sunny climate. Because actually we avoid sun as much as possible, not because we get dark, but it is hot, right? But in a sunny climate also vitamin D deficient, so maybe there are other factors other than the sunlight. Because මං හැම වෙලේම කියන දේ තමයි the only white people do research. So the research are based on white skin. This white skin research are not entirely relevant to us. I wrote that book. So our young people also, you have to think and write more books, do some research. Right. Madam can wear around and anterior aspect of ankle or anything, anywhere you can get vitiligo, but anterior aspect of shin is mostly that guttate hypomelanosis, idiopathic guttate hypomelanosis, right? So that you look for other sites for vitiligo. If that person, elderly or middle-aged, mostly women, seek treatment, come with hypopigmentation on the shin, look for other areas. You have to differentiate from guttate hypomelanosis and vitiligo. Right, time is up.
I think we have answered a lot of questions as the time permits.
Yes.
So I want to thank you, Dr. Ranthilaka R, for conducting such an excellent practical session. I think your clear explanations, the patience, and the willingness to answer all our questions made this session extremely valuable and insightful. And I hope you join with us again for another interesting session in the future as well. Thank you very much, madam.
Okay, you are welcome.